Hello, everyone, and welcome to another Learning Lunch hosted by Format Approved. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's subject is owned or owner-operated, remain independent, or join the hospital-owned ranks. This is a hot topic these days, and we have a great presenter in Mark Anderson. Before we introduce him, I just want to thank our sponsors at Care 360 for making this Learning Lunch event possible. Just a brief note on what Care 360 does. They connect healthcare organizations, community physicians, and patients to improve access to information and insights. They have a suite that combines a powerful EHR record platform with a comprehensive revenue cycle management solution and robust patient engagement tools. These applications work harmoniously to promote physician loyalty, provider collaboration, and positive patient outcomes. Care 360, connecting you to the greater healthcare landscape. So thank you again to our sponsors. Our expert today, introduce yourself, Mark.
Well, good morning, everybody, or it might be afternoon, depending on where you're at. My name is Mark Anderson. I've been in the healthcare field now for over 40 years. And yes, I did start out on the hospital side, working for 4 IDNs, Integrated Delivery Network Systems, multi-hospital systems. But in 2000, I kind of moved away from working just with hospitals, started working with physicians, became an advisor to 8 different medical societies, helping their members, physicians, understand what's required to really thrive in this marketplace, dealing with technology, financing, revenue cycle, policies and procedures, whatever needs to happen so that physicians can actually work in this kind of environment that's always changing. But I've spent over $2 billion on healthcare technology. I've given over 1,400 educational sessions since 2001. So I've been around the block a bit. As I tell most people, I've worked in over 200 hospitals and over 25,000 doctors. I kind of joke that I can't keep a job, but the reality is I'm an advisor. I don't come in and do really long consulting engagements anymore. I provide advice, provide insight to physicians, medical groups, IPAs, MSOs, or even hospitals on what's needed to really thrive in this marketplace out there. And one of the challenges I've had lately is I'm working with a number of practices that ended up suing the software vendors for not meeting the requirements. There's been a lot of articles recently about systems that did not quite meet the requirements that are out there for physicians. And there's a lot of vendors out there that provide really good software and some that have some challenges. It keeps me kind of busy on the legal side.
Yeah, without naming names, there have been some shocking, I would say shocking cases of, EHR companies faking their way through it. So, whoa.
Exactly, yes. Yeah, so $130-something million fine, those kind of things. Yeah, they're kind of shocking out there, but there's a lot of those that just affect certain small practices that have struggled. And again, they're usually not the big name vendors. Sometimes they are, but there's a lot of challenges out there. But I've also run a 2,300 doctor IPA up in New York and also one in Southern California, helping them figure out what's going to be needed to, again, survive going forward with a changing reimbursement model, the changing requirements, what's happening with the Accountable Care Act that's going on, all kind of things. We're going to be talking a lot about this today, and especially about, do you stay independent or do you join what people call the dark side, join the hospital and work in the hospital? There's a lot of options out there. We'll be talking about that today.
Well, this is a very hot subject, so I'm getting a little feedback all of a sudden. But this is a hot subject, and, here's the questions we're going to cover as you glance at those. Well, you look at the questions, I'll just say briefly, because people always ask about this. If people want the slides and they want the video recording and all of that, well, we're taking care of all of that for you. So after this session is completed, we will send you a follow-up email that has the slides and a link to the video recording for you to either review or share with your colleagues. So don't worry about that. Well, this is a great subject, as I've said a couple times. I just think there's so much buzz about this. We know this is going on a lot, and having an expert to guide us through the landscape is really a great tool and resource for our audience. So let's start. Question 1. So what factors are affecting physician ownership, Mark?
Well, there's a number of factors, obviously, and we have some slides coming up in a second about, the supply and demand for primary care physicians and specialists out there. But again, the challenge I think really is that healthcare costs keep increasing. On an annual basis, we're still seeing healthcare costs go up by 6% every single year. Utilization is up and demand is increasing, but the traditional reimbursement model is not keeping pace with underlying costs. So we got to find a different way of doing it. And that's why we're seeing more and more, the financials with physicians runs versus hospital and ambulatory practices. We'll talk a little bit about how hospital balance sheets are really becoming stressed. You realize there's 1,040 hospitals, mostly in rural America, that are facing bankruptcy in the next year. That came out from the American Hospital Association on how they actually submit their cost reports. It's amazing. We think about almost 25% of the hospitals may declare bankruptcy in the next year unless things change. We got to find different ways of doing stuff. So a lot of this is going to be affecting how and who owns the physicians out there today. But we're also talking about culture matters, because again, when you're thinking about a doctor, do you really want to work for a hospital that's different cultures than what you're used to? Especially if you've been independent for 5, 10, 15, 30 years. Do you really want to change all that? And we'll talk a little bit about what's actually going on, some of the evidence stuff that's out there today. Next slide. So as I mentioned, costs are going up, and this is the best way to look at it. Healthcare costs for a family of 4. You started thinking about this over the last 15 years. Healthcare costs for a family of 4 have increased from around $9,000 in 2002 to over $26,000 in 2017. That's your cost for healthcare. That's a 188% increase in the last 15 years, while salaries have only increased on average about 35%. So great, salaries are going up a little bit, but not at the same rate as the cost for a family of 4. So people are saying we have to do something different. And something different is what CMS has come up with, called value-based reimbursement, VBR. I'm not sure I really know about what's going on this, but they're changing the reimbursement model starting in 2018, moving away from paying for volume and paying for quality and outcomes. The goal is to improve health, reduce costs, and really improve the patient experience. What that means for the average physician is, look at that, 80% of the money you get today is fee for service. That's going to drop down to less than 18% in 2020. We're going to see full population health care where 100% is capitated. We're going to see partial capitation, condition-based care, episodic care. But fee-for-service care is really going to drop, and it's going to affect how physicians survive in this industry. Because if you think about it, 80% of your money comes one way, that's going to be less than 18% in just a couple of years, basically 4 to 5 years or less. It could even be 2 or 3 years now. That's a big effect on. And if you're not involved in value-based reimbursement around quality, reducing costs, you could be out of a lot of money. That's one of the challenges as we're going forward. That's one of the reasons doctors are looking at changing and being employed by hospitals. So as I mentioned, we're going to be moving away from that. The challenge will be is, how will payers' contract affect my decision going forward? What they're doing is shifting risk to larger healthcare organizations, large IDNs that have 10, 15 hospitals. That's why you see a lot of mega mergers going on. But to the average physician practice, you could lose 50% of your patients. What that really is that they're moving to a model where people with chronic diseases are going to be assigned to a specific healthcare system by a healthcare plan. Aetna, Cigna, United, and the Blues, and even CMS may pick 1 or 2 hospitals from now on for treating those patients. And if you're not part of that hospital, either employed by them or directly affiliated with them, 50% of the patients could move to someone else. That's going to cause concern for a lot of doctors. And again, we're only talking about 2018, right around the corner. And reimbursements will continue to very tighten. As most people are seeing, the amount of payment they're making, CMS is increasing 1 or 2% a year. The healthcare plans are less than 2 or 3% a year. But the doctors' costs are going up a lot higher than 1 or 2%. And again, new technologies around care coordination, patient engagement, remote patient monitoring are going to be required. And can physicians actually afford to buy more technology They just spent all this money on electronic health record systems and new revenue cycle management systems. That's the old stuff. Now we need new technology, and are physicians really going to pay for that again? They don't have money to pay for new technology. So again, working for a hospital might be an easy way out for a lot of people. The challenge is going to be in 2020, 68% of patients will be tied directly to one health system for all services. We're talking inpatient, emergency room, physician offices, long-term care, home health, behavioral health, everything. It's going to be tied to one health system. And these contracts are not going to go to individual doctors. They're going to go to a large system or a large IPA. You probably have to have at least 500 doctors in your network before you even get these contracts. So again, 50% of your patients may be leaving you, and 68% of all patients are going to be assigned to a healthcare system for their care. That could cause major issues for a lot of practices. Now, we do predict a couple interesting things. The MD supply will diminish significantly while the demand for their services will grow as chronic disease incidence and access through ACA expands. We're going to talk a little bit about some of the slides and the data around this on the next slide. So it's kind of hard to see this, but it's basically showing what's going on. United States is a low physician to population level. We're kind of like low, 264. Greece, Italy, Belgium, Australia, and other places have a much higher physician to population ratio. The one below, you start looking at doctor visits, are slightly higher for those over 65. So again, as patients age, there are more office visits going on. And as we all know, the baby boomers are increasing. We have a lot more baby boomers. That means we're going to have a lot more office visits going on compared to the people from 5 through 55, much lower volume of visits. And what that really means is that we're going to have less physicians available to take care of more patients. And one of the challenges, I guess, is that if you look at the first year MD enrollment per 100,000 population has really been declining since 1980. We have less physicians getting into, or less people getting into the market by becoming a first year MD compared to the population. So again, population's increasing faster than the physicians are increasing. And again, we have a lot of physicians. Think about that, over 250,000 active physicians that are over 55. What happens over time? Those doctors will start retiring. They may still work till they're 65 to 70, but again, a lot of people are going to be retiring. We're going to have a lot less physicians. Therefore, the supply is going to be higher. Supply is going to be lower, demand is going to be higher. That's going to cause a lot of effect on how we treat patients and what we do, especially if we keep doing the same way, which is paying for services versus trying to keep people healthier and reducing down the number of visits by keeping that population that have chronic disease a little bit healthier. So when you look at the overall graph, think of that, the demand. The demand by 2025 is going to be about 900,000 active physicians. And you start looking at the supply, right now we're about 750,000. So there's going to be a big gap by 2025. Now, part of that will be filled by physician assistants, nurse practitioners, and other ways of doing it. But again, we have to change the way we do things. We can't keep doing it the same old way. Something has to change. And again, because we have so many baby boomers coming out, remember, baby boomers have a lot more visits than somebody in their 20s and 30s. And a lot of people think because Medicare is covering it, especially if you got Medicare and a supplement, it's almost 100% covered. Why not go to the doctor more often than paying for it out of your pocket? I know, like me, I'm waiting to turn 65 in about a year and a half. So I can start getting more medical care just because I don't want to have to pay all that out of my pocket today. Again, I have a $7,500 deductible. Almost everything I get in healthcare comes out of my pocket. Insurance company hardly ever pays for anything. So, like a lot of people, are going to wait till we're 65 and get a lot more services.
Well, here we are to our next question, but before I ask it, I just want to remind our audience that you also can ask questions. It's not just me. If you have questions for our presenter, you can put them into the chat area at any time. We'll hold those until the end, but that's part of the fun of this, is that you get to ask questions too. So I needed to mention that. Now, the next question is, has physician ownership changed in just the past 3 years?
It has. If you look at the graph that shows everybody's looking at right now, there was a big push back in the 1990s and I was involved in a lot of this. I actually worked for a hospital chain, and we actually went out and hired employed over 500 doctors in our hospital chain. And we did that during the 90s because capitation was coming along. And then all of a sudden we started realizing that the hospitals were losing money, significant losses in financial by employing the doctors. Productivity went down, our reimbursement went down. And so starting in the late 90s all the way through about 2004, we basically diversified ourselves out of the physician practices. So think about that. We bought the practice, then we sold it back to the doctor, basically at a loss for us. But again, it's now changing. Since 2006, we're seeing a big increase all the way up to basically 2013. We've been seeing a big increase in the number of acquisitions going on of physician practices. And since 2013, basically the last 4 years, the graph, we got to update the graph when we get more data, but it's off the chart now. We're seeing big increases in the number of doctors being employed by hospitals. In some rural areas, 80% of the doctors are now employed by smaller hospitals, primarily primary care and some other specialists. But again, we have some good statistics coming up what's happening with that. But again, it's increasing dramatically. So hospital ownership of physician practices has increased by over 86% in the last 3 years, according to a new report that came out. And you start thinking about that, in 2012, about 1 in 7 physician practices were owned by a hospital. But by the mid-2015, now it's down to 1 to 4 medical practices. That's 67,000 practices are owned by hospitals. And a lot of it is larger hospitals have bought up a lot of smaller practices. They have some owned already, especially the university settings. But again, we're seeing a major change. So we're looking at a 50% increase in actual physicians being employed by hospitals in the last 3 years. So you got a number of practices and physicians actually increasing. In 2015, about 140,000 physicians were employed by hospitals. That's a rise from 95,000 just in 2012. And you start thinking about, we got 750,000 physicians out there today. They're supposedly active. So we're really looking at about 38% of the physicians are now employed by hospital systems, according to the report. But we're seeing other numbers out there. The government says that about 67% of all physicians are employed by hospitals. I think that number is a little misleading, because what they're also including are physicians that are closely affiliated with a hospital. In other words, they go to one main hospital most of the time, or one main system, but they're not employed by them. They're still independent. But again, the numbers are increasing because hospitals think they need to buy the practices again to control the flow of patients and the volume of work coming through. So why is there dramatic ownership and employment shifts are affecting different things? And I think again, it's because of the recent change in the reimbursement model. We know that CMS increasingly favors integrated healthcare systems, and they don't like the idea of having independent physician practices. You look at MACRA and MIPS, all the requirements of reporting, it's now pushing people to work for larger organizations, especially as we move to this value-based reimbursement. If the contracts go to a large hospital system that employs physicians, they will get the business. And you think about it, the hospital can provide more support staff for the physician. They can provide the technology for the physician. Again, a lot of things they can do. And one of the things the hospitals are looking at is if they have the relationship with the physician, they think they have the relationship with the patient. If the patient needs lab work or radiology work, the physicians will order the test from that hospital. If they're going to get admitted or go into the emergency room and have surgery done, ambulatory surgical center, the patient will tie most of their business back to that physician and the hospital they're all associated with. So from a hospital point of view, the hospital sees owning physician practices as a way of capturing more market share on the hospital side, which is interesting because hospital business is actually decreasing. We're doing more on the ambulatory side, ambulatory surgical. Length of stay is down. Hospital admissions are up a little bit, but total patient days are down. It's interesting that when I look at physicians are the ones that really control everything. So why should the hospitals own them? It should be the physicians owning the hospitals, a better way of doing it. But a couple of years ago, under the Obama administration, physician-owned hospitals were no longer allowed. If you were sunsetted in physician-owned hospitals, But now you've got administrative people owning the hospitals, telling physicians what to do. Personally, I think it should be the opposite way. Physicians should be saying everything. But that's the way things are right now. The PwC did some research in 2017. 66% of physicians really want to be closely aligned with their hospitals. And it's really interesting how you look at the breakdown. 63% of the cardiologists want to be employed. 58% of primary providers want to be employed by the hospital. And it kind of changes by specialists. But again, all physicians are saying we're interested in being employed by the hospitals. They're going to look at it. 79% of all physicians surveyed thought they would become more integrated with the hospital in the next 5 years. And that doesn't necessarily mean employed, but that means they're saying they're going to plan on working with one healthcare system. Maybe it's an MSO or an IPA working with a hospital or employed by the hospital. But we're seeing a lot of doctors being more closely affiliated or employed by hospitals over the next 5 years. Only 21% of the doctors say they're going to stay totally independent in the next 5 years, which is kind of alarming given that it's a higher number today. But by specialty, it really does change. Interesting, the ones that are most interested in being employed are the cardiologists, psychiatrists, surgeons, OBGYN, mostly because they do a lot of their work in a hospital setting. Of course, anesthesiologists do a lot of work. Emergency medicine, you can see them because they're in the hospital. The least interested in employment, which is kind of interesting, neurology, gastroenterology, orthopedics, urology, mostly because a lot of that work outside of radiology can be done in an ambulatory surgical center. And we're seeing more GI doctors and orthopedic and urologists and some neurologists owning their own ASCs, ambulatory surgical centers. So if I can own my own surgical center, my own hospital, maybe there's a number of surgical specialty hospitals out there for orthopedics, they want to stay independent. But there's another group, the family medicine, dermatology, pulmonology, ophthalmology, where they're not as big in working in the hospitals, but they feel an interest in being employed. But again, most of the doctors want to stay independent, but we're seeing the trends move towards more and more doctors wanting to be employed by the hospitals, or at least interested in looking into it. Partly because if they buy your practice, you get money up front. The amount of work you have to do actually will decrease down because of requirements, the way they do things. So you can have maybe less work, more coverage for you, and more money in your pocket because they're going to pay for your practice. They may not pay you as much money as you're making today, but you'll have money in your pocket because they bought your practice. Next slide.
So what is a little feedback there? What is the difference in thinking between hospitals and independent physicians? You talked about the culture issues. I don't know if that's part of it, but tell us more about this.
Yeah, if you think about it from a physician perspective, the hospital becomes a shield for them, something that backs them up from malpractice cases or financial things, but it helps protect them from reimbursement cuts. I'm getting a salary. I no longer have to worry about what Blue Cross, Aetna, Cigna, or CMS is doing. I'm getting a salary all the time. And everybody always talks about healthcare being recession-proof, but not really. When recession goes down and changes happen, patients don't have extra money to pay for healthcare. So patients will put off getting certain tests done. They won't come to the doctor as often. They may put off having a surgery case done. But if you're employed by the hospital, you've got a guaranteed salary no matter what. And again, your malpractice rates will probably be a little bit less because instead of being a 4-doctor practice, you're now part of a 500-doctor group in maybe a 500 or 600 bed hospital. So the malpractice rates that you're paying go down a little bit. And in most cases, the hospital pays for your malpractice for you. Politically, there's a whole bunch of issues going on too. What's going to happen to the Accountable Care Act? Is Congress ever going to get their act together and change something? Who knows? So again, I don't know what's going to happen politically. Maybe I just want to join somebody because I don't know what's going to happen. There's a cultural shift too. Democratic shift more toward younger physicians. They may be interested in more, being employed by the hospitals going forward. The work-life balance. I don't want to have to work 80 hours a week like we did during medical school. And also a lot of doctors are saying, I really don't want to run a small business. It's getting too complicated with all of the rules and regulations and payroll. I'd rather, take care of patients, take care of the medical side, because that's what I want to do. That's what I was trained on, is how to take care of patients, not how to run a business. So a lot of doctors are thinking, maybe it's time to get out of this. On the hospital side, they're seeing something totally different going on. They're seeing shrinking margins. As I mentioned, over 1,000 hospitals are facing bankruptcy in the next year. But they're looking for ways of basically keeping their income at a certain level. Referral network going on, advantage reimbursement driven by economics of scale. There's a lot of things going on. We can actually keep our income higher by making sure the doctors refer all the business back to the hospital. And they're also looking from a human resource point of view. I need call coverage. I need hospitalists. I need to make sure I have enough anesthesiologists, radiologists, pathologists, and family physicians bringing business into it. So again, it's the human resource side. We want to be able to control the hiring of new physicians coming in and maybe hire more younger physicians or more PAs and nurse practitioners. So looking at different ways of doing it. Politically, they have the same issue everybody else has with the healthcare reform. Is it going to change? What's going to happen? But again, there's been a lot of talk about moving to value-based reimbursement based on quality and care and patient satisfaction. We know if we're a hospital, if we control the physicians, if we can help the physician provide better services, maybe provide them additional assistance with PAs and nurse practitioners, we think we can help drive a lot of changes in value-based reimbursement, quality, and performance. By doing that, we think we can actually increase our reimbursement. What we don't want to do is lose contracts because we don't want to participate or we don't have enough physicians. If you don't have physicians on part of your panel, you will not get these contracts. And that's why hospitals are saying, we want to have enough physicians on our panel. The easiest way to do that is to employ them. So a lot of things going on that are really going to change in the near future. Next slide. So what is another concern of the physicians? 95% of physicians say losing their wealth is their primary concern. And so they're worried about having less money coming in, costs going up. And there's effect on everything from all these new regulations that are out there. Things seem to be getting worse for a lot of the practices, all these different reporting things you have to do. I mean, the whole push towards EHRs and MIPS and MACRA have caused a lot more work for the physicians. A lot of issues with liability and more malpractice lawsuits going on. It seems like we're hearing more and more just almost nuisance lawsuits a lot of times just to be able to get more money out of the doctors. But again, the doctors are saying, I want to find a different way of doing it. I don't want to have to worry about my income. I don't want to have to worry about my income being reduced. So again, it makes sense the doctors are saying, well, wait a minute, let me think about being hired by the hospitals. So 70% of the practice acquisitions that have occurred in the last 3 years have come by physicians presenting themselves to the hospitals, not the hospitals looking for the physicians, but the physicians saying, I'd like to be employed. I'd like to change what I'm doing. And again, they see a lot of issues dealing with the ACA, changes in reimbursement, other kind of things. And it's kind of, they're really split about how they think about the rules and the law relating to ACA, but we're seeing more and more practices go to the hospitals and saying, will you consider it hiring us, buying our practice out, and just keeping us connected to your network? So it's not just hospitals going after it. Physician practices are also looking at being employed. So we're seeing more aggression by the physicians lately.
There's so much that's interesting in this, Mark, I have to say. And one of the things is I had gotten the sense that physicians were really split about the ACA, but seeing the numbers there confirm it is certainly interesting.
I always found it interesting that 31% still think we should have a single payer system.
Right.
I kind of wonder, are those all young doctors? They only work in university settings, you know, it's that kind of thing. So I'd like to see more breakout from the reports that they do, especially you got 31% saying a single payer system can accomplish this. But I think if you think about Kaiser, they're a single payer system. They own the hospitals, they own the payer, and they own the doctors. It's one single system. Their cost per unit is a lot less than a lot of other people. Mayo Clinic, Cleveland Clinic, they do a lot of the same things. So you can see why a lot of the bigger groups believe in that. But I think most doctors still think that we need to change our reimbursement system. And, you know, ACA, I think, as I said, 55% of doctors think the ACA whole law should be repealed. And one of the challenges is with the ACA is that our out-of-pocket costs have skyrocketed in the last 5 years. Over 100% increase in out-of-pocket expenses for patients just in the last 2 years. That makes it hard for doctors because doctors are not the greatest at collecting from the patient. Our billing team does a good job collecting from the insurance company, but now I got to collect from the patient, much harder to do.
So how does physician ownership affect overall medical costs?
It's interesting. This is a study that was done back in 2017, or early 2017, excuse me. And if you just want to compare the best non-hospital physician groups that are out there, so we'll take the best of the non-physicians, compare it to the rest of the hospitals that own physician groups. Overhead cost, 58% of a physician's revenue and best non-physician practices, non-hospital owned practices, 58% of all their money coming in is overhead costs, which is amazing. So the doctor has to, bill $2 and $1, more than $1 goes to overhead. You start looking at a hospital, 83% of its overhead. So you're talking about an 80% increase in overhead costs between the best independent physician practices and the normal rest of the hospital IDNs out there. That's a major interesting point. 80% more cost for overhead. Charges, gross charges per FTE physician, full-time equivalent physician. As I said, physicians that are in private practice generate about $1.3 million in charges. That's not reimbursement, but charges. And in the regular hospitals that are owned the physicians, 755. So you're seeing a 45% decrease in billable charges when they work for the hospital. Now that also means less productivity, less patients being seen, but they're getting less money. Also, you look at physician revenue value units per FTE. Again, you're looking at a 30% decrease from a independent physician practice compared to the average hospital that's out there. More importantly, I think is the last number. Total MD revenue after operating costs per FTE. A private physician in a private practice, and this is average over all hospital multi-specialty, is $351,000. In a hospital setting, the overall money comes into the physician basically $69,000. That's an 80% reduction in actual revenue coming in. Now, the private physician may get paid $351,000. The hospital may pay that doctor $250,000, but the hospital is only getting $69,000. It's a major decrease in revenue coming into the hospital. So you always wonder, why are hospitals buying practices if they're not making as much money? Well, part of it is they all think we're going to be the best of the best, and that shows the $261,000. We think we're going to collect $261,000 in actual revenue per physician. Yeah, that's the best. That's the top 5%. The rest of the hospitals barely make enough, and they're actually losing money, depending on what they're paying the physician. But they assume it's okay to lose money because they're bringing more business into the hospital. But as I say, if you lose $2 per patient, adding another 5,000 patients, doesn't make you more profitable. You basically need more money, but the overhead cost is 83%. So if I see more patients, my cost really doesn't go up because 83% of all my cost is overhead. It doesn't change that much. So they think volume increases actually will drive business benefits to them. But the one thing I found working in hospitals for 45 years, only 1% of the hospitals out there today have a cost accounting system. They know what their actual costs are. Everything's built around charges and reimbursement. They don't really know what the cost. What does it cost to take care of 3,000 diabetic patients? They have no idea. And that's one of the problems today. You go work for a hospital, they don't necessarily know what it costs to do things, and that becomes a troubling for most physicians later on.
Do you think this is a difference in physician motivation, or what explains this?
Well, again, part of it ends up being is when you're employed, and we also know that physicians in private practice, depending on the specialty, may see 35 to 40 patients a day. In a physician practice that's owned by the hospital, a lot of times they're only scheduled for 20 to 25 patients a day, and a lot of times you'll have a much higher no-show rate. So we've seen actual number of visits per patient, per physician, drops to around 15 to 16 compared to 40 in a private practice. Again, if a patient doesn't show, it doesn't affect the doctor's reimbursement. And if you're owned by the hospital, it definitely affects you if you're a private practice.
Right.
So I think there's a lot of things. Plus the other part is, if I'm a physician that's owned by the hospital and I see the patient today and I admit the patient tomorrow, that physician bill does not get paid for. It gets rolled into the hospital payment. So if I'm a physician in private practice, I get paid, the hospital gets paid. If I'm owned by the physician, by the hospital, like for instance Medicare and Medicaid, the doctor's portion gets rolled into the hospital payment. We don't get paid. We get paid on a DRG or a per diem rate. That money coming from the doctor no longer shows up. So automatically you lose anytime a physician sees a patient within basically 96 hours of the patient being admitted to the hospital, the emergency room, you don't get paid for it as a hospital. So that affects it too. Interesting is the next slide. Here's where you really see the difference in how many procedures versus physician-owned, what the average charges are. We find that the average charge per procedure is a little bit less in a hospital than the physician-owned practice, but we're doing a lot less procedures. And then it really goes down, look at the bottom line here. Net income, excluding physician salaries per procedure. In a hospital, we lose $21 per procedure that we do, compared to making $1 in the physician-owned practice. Of course, why is it only one doctor? Because most times, whatever profit the practice has goes to the salaries of the physician. So the goal is not to make a profit. You know, why pay tax on the business and the physician both? But again, hospitals are losing money when they actually see own the physician practice. A provider cost per procedure is higher. The operating cost per procedure is higher. So we're basically looking at a $16 reduction in cost just in the cost for doing these procedures if the hospital owns the practice. So again, why would a hospital bother do it? You're going to lose money if you're a hospital buying the practices. Because again, it's all about volume. It's about controlling where the tests go. It's all about controlling value-based contracts in the future. Hospitals are willing to lose money by owning the physician because they believe they're going to get more contracts in the future, bigger contracts. They'll be able to control the market more if they're bigger. But again, for the physician, why not? You can actually get more money potentially, or really lower your overall overhead, lower your cost. You may not make as much money, but you'll also be working less hours. You have to really look at all that. So as I mentioned before, the challenge with the hospitals is that it really does hurt the hospital's financial condition. Because we're buying the practices up front, we may be providing more benefits to the doctors than they had in the overall, and it takes a while to get that money back. We're seeing the hospital acquisitions hurting the bottom line of a hospital, decreasing their overall income because, again, it takes a while to recoup those dollars coming in. If I'm paying out $300,000 to the doctor and I'm only getting in $200,000, I'm going to lose a little bit of money, especially if we're buying the practice up front, around salary guarantees, about physician integration, or even practice acquisition. I got to pay to buy the practice. So it is hurting the hospital's balance sheets. But again, hospitals see this as a positive. You don't see very many businesses saying, hey, I want to go out and buy something, I'm going to lose money on it. Hospitals see that as a positive, which is interesting because they see controlling the market. And again, by controlling the market, I have a better chance of getting bigger contracts with Blue Cross, Aetna, Cigna, United, and CMS. So they see that as the value. Even though they're losing money on it, they see a value owning all this. Next slide. Yeah. So what about the cost out there? There's been a bunch of studies, and hospital purchasing physician offices raises healthcare costs. We think costs are going up. Because again, it's not that the cost goes up, but the number of procedures being done, the number of visits being done goes down compared to the cost. So again, major factors dealing with that. Robert Wood Johnson did a couple of studies looking at all this analysis of all this. And so we're not really seeing that owning the physician lowers costs. We're actually seeing it actually increase costs a little bit. But the assumption again for hospitals is that if I own the physician, I can control the referral network. I can control where they send business to the specialist or to radiology or where the surgeries go. They're looking at a lot of things about controlling access to care. They believe that is a bigger factor than the dollar amount. If I control access, I can control contracts going forward in the future, and I can control where doctors send their patients. And because overhead costs are at 83%, I can add a lot more patients on, but if 83% of all my costs is overhead, that means it doesn't change. If I have one patient or 1,000 patients, my overhead's still 83%. So more patients is better for the hospital, even though they may be losing per patient in the beginning. They see it as a long-term gain in the future.
So we touched on this a little bit earlier, but this is an important one. What about differences in culture?
Yeah, I think there's a big difference in the culture because you think about that, a physician is really a professional. They look at, they have a more of an expert culture out there. They're independent. They like rapid decision making. Their consensus is really built around a few doctors talking about it. They don't have to go through big committees. They were trained to work independently, and it's all about the medical side, not necessarily about the administrative side and financing and everything else. It's all about how they want to be a professional versus the hospital, culture is more collective. We embrace our organizational mission, value, and the vision out there. We don't want any kind of conflict. We're not going to take any risk, but we really do respect the hierarchy of, physicians are in charge, but we have administrative people, we have department directors, we have, vice presidents. It's more of a hierarchy where in a physician practice, the physician is the CEO of their practice. Here, the physicians in the hospital setting is more of a worker, even though they do control almost everything with their pen. But again, they're more trained on social and management, running of a facility. They really are into delegating the work down to groups and having multiple meetings going on. Decision making takes a lot longer going on. A doctor can just say, I'm going to do this tomorrow. The hospital, a lot of times, it may take 8 months to do anything because of budget structures. They can't make decisions. So there's a lot of changes going on around how a hospital sees how they run things compared to how a physician. And a lot of times physicians that are employed by hospitals get very frustrated because the hospital moves too slow. They would open another clinic. They want to try a new procedure. They want to try different medications that they like to do. They want their own best practices. And the hospital says, wait a minute, doctor, you're now employed. You have to do it our way, a consensus way. We want 100 doctors to agree on the protocol, not just you. So doctors get very frustrated when they work for hospitals, especially if they've been in an independent practice in the past. If you're a new doctor right out of medical school, it's not an issue because you're not used to working independently for 5, 10, 15 years, or even 30 years. But it's much tougher on the doctors that have been running their own practice for a number of years. The other part, I think, is that hospitals emphasize value over productivity. Again, that's why we always say that productivity actually goes down. It's all about the value. You may see less patients today, so we're not focused on the volume, but it's all about the increased value. How much can we do help the patients come out with better outcomes, especially around value-based reimbursement, as I mentioned. We want to make sure that whatever we're doing provides better care for the patient, better outcomes, better efficiency that way, not productivity-wise. So again, when they're looking at things totally different, they're not thinking of churning numbers, getting 40 patients through the office every 5 minutes. They're looking at let's provide a better suite of care. And they also believe in more PAs, nurse practitioners, that can help out to help reduce that cost down. So there's a lot of changes going on from the hospital side. They're looking at it from a different point of view than the culture that a physician think about things. And you can look at it both ways. Both ways are good. If you look at what Kaiser, Mayo Clinic, and Cleveland do, and the universities do, they provide excellent care, and they provide it a different way than a physician in an independent practice might, or a physician that's owned in a community hospital. Different cultures, different ways of doing things. And that's why as a physician, you have to think about, do you want to work for that one community hospital or that one integrated delivery network? If you're working for one hospital, you're then limited to that one hospital's availability for, say, surgery or for admitting to the patients to the beds, where today you might work in 5 different hospitals. So it may limit your services. But again, if you're getting a salary, it may not matter that much to a lot of the physicians because they're still getting their money, less hassle, less cost to them. They don't have to worry about the administrative burden, a lot of this stuff. So it does, I think, works out really good for physicians, at least consider being employed.
Well, this is a question we've touched on a little bit. Will my annual salary increase if I join a hospital, if I'm a physician?
Well, a lot of that's dealing with obviously the specialty and all the healthcare reform laws out there, things that CMS are doing around Medicare rates and Medicare and Medicaid rates. But we're seeing that depending on the physician, especially in the hospital, obviously, that the physicians will take home more money than they did before. Again, they'll make less money because, again, the overhead, you think about, again, for every dollar I make, 53% goes to overhead. Doctors have no overhead if they're employed by the hospital. So in a lot of cases, the doctor may see less patients, take home a little bit more money, but the potential of getting a 30% increase because I do a lot more work doesn't happen. So you're going to get used to a salary coming in versus, you may make, 50,000 one month, 30,000 the next month, 80,000 the next month. You're not going to see variations. You're going to get a nice salary going forward. You're not going to have that big increase or that big profit sharing at the end of the year that you might have, especially with a group practice. So things are going to change for the doctors, but it's more consistent payment. You may not make as much money as before because you're seeing less patients, but the quality of life, so-called, improves. You have to spend more time with the family and less time in the office. You may have to be on call a few more times, but again, the overall value to a lot of physicians actually increases, even though your salary may stay the same or may go up. But again, I think depending on the specialty, there may be a higher salary increase because of shortages of physicians, supply and demand. Doctors need to, if hospitals are going to employ doctors, they need to get a good balance. They may provide a higher incentive, maybe not on pay, but on buying your practice. Can you imagine getting paid $500,000 or $1 million for your practice and getting your same salary? It's like getting a bonus the first year and you get to relax a little bit more because you don't have all the administrative burden you had to worry about in the past. So I don't necessarily say salaries will increase if you join the hospital, but I think you'll have more money in your pocket because they'll buy the practice and give you a salary. But that reducing the administrative burden, not have to worry about hiring and firing people, all that accounting stuff you have to do, all the revenue cycle, let somebody else do all that for you and just practice medicine because that's what doctors were trained for. And I think it really does come down to, as a physician, if you're going to look at being employed by a hospital, definitely get somebody who specializes in contracts because you have to look, this is a contract to be employed, buying your practice, all other kind of things. Get somebody who knows how to do this. The benefit plans may be different. The amount of money they pay for your practice, you want to make sure you're getting the right amount of money. If you're a new physician just coming out of medical school, maybe the hospital will pay off all of your school debts. That's a great value for a lot of physicians. But before you get employed or consider employment, make sure you get somebody. It may be a lawyer or somebody else that specializes in physician engagements with hospitals. Get somebody that can help you understand the requirements, the benefits, the negative parts. Make sure you have an employment contract that meets your requirements, not necessarily the hospital's requirements. I've reviewed probably over 1,000 contracts in the past for physicians. Some of them are good and some of them are terrible for the physician. So don't just take what the hospital says as that's the only way of doing it. Negotiate the contract, but get somebody who actually specializes in this that can really help you go through it. You want to maximize your reimbursement, maximize the payment of either paying off debt or paying for your practice, and having a higher quality of life value to you. Again, you may be on call more often than you were in the past, but again, I think the overall value can be very beneficial to the doctor if you get help.
All right, so what are my alternatives then?
Well, as we like to say, eat or be eaten kind of thing, it's like the shark out there. Who are you going to be? How do you find a way of increasing demand for your services? Is it marketing? Is it advertising? What can you do? You have to keep the volume of patients coming in. And you come back and say, I have 5,000 active patients today. I don't have to look for business. But remember, value-based contracting is going to come into effect 2018. Those contracts are going to go directly to a hospital. That hospital will basically give that work to their employed physicians first, certain specialties second, and you may be third on the list. You may not get access to any of those patients. So just think about you're busy today. You've got 5,000 active patients. You're seeing 3,000 visits a year. All of a sudden, 50% of those patients are now reassigned to another physician, and you lose that business. So you have to think about, what are you going to do? Maybe just a hospital partnership rather than acquisition. Maybe joining an IPA and MSO. Being an independent physician out there is going to be very hard to survive in the next 3 to 5 years. And it'll start affecting everybody in 2018, because that's when CMS is moving 50% of all their reimbursement to value-based contracts, and those are going to go to large organizations. Aetna, Cigna, United, and the Blues have all committed to doing 50% sometime in 2018. Maybe that'll be 19 or 20, but we're going to see major shifts in contracts going to larger healthcare organizations that own hospitals, own urgent care centers, have their own surgical centers, and own the physicians. So again, work is going to be changing. You got to find something to do. I think a large IPA is a good way of going, because I have a lot of groups right now where the IPA now controls everything. You may have the one I did up in New York and one in Los Angeles, 2,300 doctors, and there was like 11 hospitals part of it. The hospitals didn't control it all. The IPA did. The independent physicians got together and said, we are the decision makers. We decide where we're going to take our patients. Healthcare plan, we want those contracts because we control the physicians and already have the relationship with the hospitals. And my personal view has always been, physicians should be running this, not the hospital side. Yes, even though I worked in hospitals for 25 years as part of the corporate staff, I still believe physicians are the ones that should be controlling healthcare. Us administrative people should be supporting the physicians, not controlling the physicians. But that's just my personal view, of course.
So as a physician, then what should I be concerned about?
Well, as an independent physician out there, I'd be worried about these large hospital systems could really dominate the market. We're seeing in small communities where the hospital now owns 80, 90% of the doctors, and they control everything. Or in larger communities like in Houston, fourth largest city in the United States now, basically 3 hospital chains control about 80% of all healthcare today. And if you're an independent physician, but these 3 hospitals control everything, what do? Do you work with all 3? Do you work with 1 or 2 of them? Do you stay fully independent? It's very hard to decide what to do when these mega mergers are going on. And again, being an employed physician, one of the questions are, patients will not have a choice of the specialist. If I have the contract for the healthcare plan, say Aetna's with Memorial Hermann Hospital or Methodist Hospital, and they control everything, that means the patients are being assigned to that healthcare system, and the patients don't have choice on where they can go. Remember the old saying, if you like your doctor, you can stay with your doctor? Well, that really goes away under value-based contracting, because the contract goes to the hospital, and that doctor that you're used to going to may not be part of that panel. The hospital may have their own doctors. And now as a patient, if you want your insurance company to pay for it, the way they do it, you have to go to this different panel. So patients lose the control over who they want to see and what they want to do and where they want to go for services. I have to go to that hospital system. I don't get to go to the small community hospital down the street. And again, you kind of wonder, if you're an employed physician, will you be pressured to order additional ancillary services, more x-rays, more lab tests? The interesting thing is, under the Obama administration, where they basically outlawed physicians owning hospitals, was because of that same reason. They were worried that if the physician owns the hospital, they're going to order a lot more tests, they're going to have more patients being admitted to the hospital. But now they're moving towards an approach where they want the hospital to control it all, and maybe the physician will provide more business to that one hospital. But under value-based contracting, we don't get paid for any services. We get paid to take care of a patient. So if we do 1 test or 100 tests, we get paid the same amount of money. So again, there's not going to be that much of incentive to actually do tests. The incentive might be from the hospital side to tell doctors not to order as many tests. Don't do an MRI when you can just get a CAT scan done. Don't do a CAT scan when you can just get a simple x-ray done. The hospitals may be telling doctors what they should be doing more than what the doctors want to hear. And ultimately, healthcare will cost more because the providers will be driven, have different motivation for reimbursement and other kind of things. So the cost per unit is going to go up, But again, if we keep people healthier, if I can reduce down 1 ER visit per year for every diabetic patient, I more than pay for all the other things going on. So it's all about reducing services by keeping people healthier. That's a challenge because we've never been paid to keep people healthy in most cases. We get paid to keep people that have medical conditions medically feeling better. And in the future, in our value-based contracting, we're going to get paid to keep people healthier, to reduce down the number of admissions, to reduce down the number of ER visits, maybe actually increase office visits by reducing ER visits. Remember, I can have 20 office visits for every ER visit as far as cost. So yeah, maybe that's the way we're looking at how do we reduce costs by reducing the amount of services needed by keeping people healthier in the future. And that's going to be a tough one. People are not used to doing that. And it's going to be a tough transition from medical care to health care, but that's where we have to go.
All right, well, we have a few minutes left to take questions from our group. So if you have a question for our expert, please do type it into the chat area and we'll share that with him. We have just a couple minutes left. You know, one of the things I was struck by, Mark, is that, you know, whatever happens with the ACA and with Congress, macro MIPS is really pushing value-based performance, and it passed with a huge bipartisan support. So it doesn't seem like that one is likely to go anywhere.
Yes, value-based contracting bundled payment is approved and supported by both sides of Congress and the Senate. So ACA may hang around for a while because they can't make up their mind what they want to do with it. But movement to value-based reimbursement is supported by everybody on the government side and the healthcare plan side. Think about it. The healthcare plans know that if they move to value-based contracts, every dollar that they move to value-based contracts is going to save them 20 cents. It's 20% reduction in health plan cost when I move a dollar to a value-based contract, because they're putting the hospital at risk. And the hospital only gets a very small percentage of the dollars unless they show that they can improve quality, lower costs, and they get like we call it a bonus on top of it. But for the average diabetic patient that costs $18,000 a year, the hospital may only get $12,000 to $14,000. So the healthcare plan automatically saves money. It's up to the hospital and the physician to figure out how to provide better care at lower cost, which we've never had to do before.
And the administrative side of this is also challenging, as you said. I have to think that there's at least some physicians out there, and you talked about this, who are simply just overwhelmed by the administrative demands of keeping up with these programs. I mean, so if you have lots of Medicare reimbursements and you're now trying to participate in MIPS, it's not easy. There's 4 different, performance categories, and you've got to do this and that. And I can see how it would be very appealing if you could take that and sort of offload that to the administrators at the hospital. I mean, you're still going to have to do certain things, but you don't have to figure it out. I can see how that alone would be appealing to some folks.
Yeah, shift the responsibility of reporting to an administrative person. Now, you may have that within your office, but again, the office is run by the physician. In a hospital setting, the hospital is run by administrative people. They have a lot of support people to do these things. So let them worry about the reporting. You still have to do your clinical service, but the reporting side, let somebody else worry about all that. Just take care of the patient, provide better quality care based on best practices. That's what they were trained to do. Most doctors, they were trained 10, 15, 30 years ago, didn't have a lot of administrative training. They would hire an administrative person, but the costs are going up. The reimbursement's going down by procedure. More denied claims, clean claim rate, all this other kind of stuff. Denials are just increasing. It's amazing how doctors can actually stay in business with all the administrative burden on them. Remember back in, it was like 2000, the average doctor had 3.2 employees per doctor. In 2017, it's now 5.5 employees, and most of that's because of overhead costs for administrative, the burden that's out there today.
Well, that's
it's a lot easier.
That's another great statistic. And it comes at the end of a presentation that was full of so much valuable information. I thought this was great, and I'm sure our audience appreciated it too. This is, you hear a lot of buzz about this, but this is really a great inside, very analytical view of what's going on. So thank you so much, Mark, for sharing your expertise with us today.
I'm glad everybody was able to join, and I guess they'll be able to listen to it and actually see the slides in a few days, it sounds like.
Yes, we're going to send those out after the session as soon as we get them ready. So everybody will be able to review, and this is one I would definitely share with folks. If you do have questions, you can send them in to us. If it occurs to you later, send it in to us. Just write to format approved, and we'll be happy to pass those along. I want to thank again our sponsor, Care 360, for sponsoring this event. They are very generous in allowing us to make these events possible. Remember that Care 360 combines a powerful EHR platform with a comprehensive RCM solution and robust patient engagement tools. Their applications work harmoniously to promote physician loyalty, provider collaboration, and positive patient outcomes, and that feeds into everything that we're talking about today in terms of, having to meet these new program requirements and reducing costs and being efficient. So if you'd like to learn more about Care 360, you can see their website there is www.care360.com. Beyond that, again, you will get the slides and the video and an email after this. And one more time, I'd just like to thank our expert, Mark, for joining us today.
Thank you. Bye-bye.
All right, folks. We'll see you next time for the next Learning Lunch. Thank you.